All righty, so we ended up last time talking about a displaced medial collateral ligament tear, which we say were rare but may require surgery even today. So this was a proximal displaced MCL medial collateral ligament tear. Here we can actually see a medial collateral ligament tear. Obviously, there's a lot of motion here. The patient was in a lot of pain, but we can see this is a medial collateral ligament which is displaced, but the actual medial collateral ligament is displaced into the joint space, not just superficially. So that's another one that might require surgery.
Well, that one was a dislocated knee, John, I think.
I don't remember. It certainly could have been. Yeah, likely.
Otherwise, it would not have been sucked into the joint like that, and it subluxed. The knee is subluxed anyway.
Yeah, right. Tayson, what do you think of this one?
It's a bad news situation there.
Yeah.
I would think about nerves and vascular system problems.
Yeah.
So it looks like the MCL is torn proximally with the edema.
The what?
MCL.
Okay. So what's happening here? What is this? This is a little different than the others. How is it different?
Did it shear off a piece of the cortex too?
Okay, so this is actually a bony avulsion fracture, right?
Yeah.
So this is one that also may require surgery because you want to make sure that there's healing of the bone and the proper positioning of the bone. And if there's displacement, that might require repositioning the bone fragments so they heal properly. So these are all pretty rare events in medial collateral ligament tears, but they may be significant.
On this one, I would like a CAT scan.
Okay, good. Yep.
So here again, looking at the proximal attachment of the MCL, there's edema and just maybe an avulsed fracture fragment.
Right. And here you can see the bony changes in this particular case. So this is another bone avulsion. Okay, next.
All right, so we have a 15-year-old male injured on a trampoline. Looks like the ACL is torn.
Yeah, so you can see not much of an ACL there. You got the coronal images.
Looks like there's also a tear of the MCL as well, proximally there. Yeah.
And you can see the bone injuries here in this particular patient by pivot shift mechanism here, and probably a direct impaction contusion on the medial side. What's happening over here?
Looks like it's probably another avulsion.
So what do we call that?
The IT band insertion there.
This is a little too posterior for the IT band. You can also see a little bony avulsion over there as well. So this has a specific name, more important in the plain film days. You couldn't see the ACL directly.
Is that a Sagittal fracture?
Yeah, it's a Sagittal fracture.
Sagittal is a tibia on the medial side, right below the meniscus. That's a Sagittal fracture. This is
It's
on the lateral side, and I forget the name for that thing.
A Sagittal is on the lateral side, right, John? It's that anterior lateral band of the capsule where it attaches to the bone here that avulses off here. There's a reverse Sagittal, which is on the medial side, which is more associated with posterior cruciate ligament tears. Okay.
It looks like here we have a tear of the distal MCL.
So this is another uncommon kind of MCL tear, which is the distal tear. And as I've kind of alluded to in prior discussions, this is the distal insertion commonly occurs inferior to where we image with small field of view. So sometimes it's out of the plane. So what you look for is kind of a wavy appearance to the MCL. It's not taut anymore. So you have to be concerned about that, especially if you see soft tissue edema adjacent to the distal end. And this is a distal avulsion. Now, typically, in this day and age, if the distal end is close to the bone, it usually heals pretty well, and it's usually not surgically corrected. But occasionally there is a retinaculum here. If it's displaced away from the bone with soft tissue separating the distal part of the MCL to the bone, then that might not heal properly. And therefore, that might be a surgical candidate. So you have to look for that. I personally have never seen that. All the ones I've seen have been adjacent to the bone, but I've seen other people present cases where there's displacement with soft tissue in between, which has required surgery for treatment. So that's important to comment on when you see.
I wonder what the pace. Are there some tears in there?
I'm sorry, John, I didn't catch that. Say that again.
Pace and Serina.
Pes anserina? Yeah, that would be more posterior to this. We're anterior.
Yeah, no, that's why I'm asking you.
Yes.
What do you think that might be? It looks like there's a lot of edema over there.
Over here. I don't remember whether there was an abnormal pes anserine tendons in this case or not, but they certainly could be. Okay. Tayson, what do you think of this one?
But excuse me, that might just make you think about the repair.
Right. Yeah, especially if it's displaced superficial to the pes anserine tendons. That's right.
Right.
So what do you think of this one, Tayson? This is one where we're a little, maybe a tiny bit more posterior in this one.
I think there's a little undulation to the MCL, and the distal portions are
attachment. So that's another distal tear, and this is probably one of the pes anserine tendons here. So like John was referring to, so if the MCL is displaced superficial to the tendon here, then that may represent a surgical case.
You know, one of the tendons is torn.
Yeah.
Or more, I can't say.
Yeah. Okay. So I have a question on this particular one, LER. Is there contrast enhancement?
Yeah, looking at the T1, no, I don't see.
Here's a T1 pre. Here's a T1 fat sat post.
Oh, it's difficult to tell, isn't it, with the fat set, if it's not the same sequence pre and post.
Okay, so here's the T1 fat sat pre. So now what do you think?
I'd say no.
It's probably no. It could be minimal enhancement, but it's certainly not marked enhancement. Again, just to let you know, again, there are many people, it's common practice to do a T1 non-fat pre and a T1 fat sat post. And if you see it bright, to call this enhancement. I just strongly urge you not to do that. Unfortunately, some people get in practices where they already have established protocols and they don't have T1 fat sat pre on all the cases, and that can really be difficult. But need to correct that, because this is not enough enhancement to make this anything like in neoplasm or acute inflammatory disease. So for all intents and purposes, this is not an enhancing lesion. It may be minimally due to a little hyperemia, but it doesn't put it into the category of acute inflammatory disease or neoplasm.
My question is, why do this study?
Why give the contrast?
Yeah.
I don't think you should ever give IV contrast or intra-articular contrast in a knee study unless you're evaluating a known soft tissue mass. That's my opinion, but it's not uncommonly, unfortunately, ordered by referring physicians. And in the United States, by federal law, a radiologist cannot change an order. So if it's ordered as a with and without in the United States by a referring physician, the radiologist has to do it as ordered or call the referring physician and have them change the order. So commonly that's not possible. So we will typically do what's ordered. Okay.
I'd call the doctor.
Yeah, unfortunately, with a big practice, that's just not feasible. But I agree with you, that would be the best if you could. But we generally don't see a case until well after it's actually done.
Yeah, I understand, John.
Yeah.
Unfortunately.
Yeah. So who's next?
It's me. So what MRI features correlate with clinical grading? I say whether the fibers are still in continuity or not, and maybe the degree of edema.
So what studies have shown, like this particular one, is that MR typically overestimates the injury based, if you compare the MR grading systems to clinical grading systems. And the things that correlate with actual clinical instability are waviness of the MCL, injuries to the deep MCL, which is basically the capsule, not the superficial MCL. If you have concomitant ACL and a posterior medial corner injuries, then those are clinically significant. You know, the bottom line is it's important to diagnose medial collateral ligament injuries because they may be a source of symptoms, and you may determine why the patient's symptomatic. And the vast majority of time, if it's an MCL tear, it's going to heal on its own, so you can reassure everyone that the pain's going to go away. If we see any of those unusual signs of instability, then they may be surgical lesions. That's why I went through those unusual findings.
I wonder where the clinical instability comes from. Acute injuries or delayed injuries?
Yeah, I think this paper was acute injuries.
If it's acute, like within half an hour, you can make a diagnosis that makes sense. But you wait for 24 hours and it will not make sense. So I will buy the MRI after 24 hours, then a clinical examination. Unless you wait another couple of weeks or a month or so. So this doesn't make sense unless you're on the field, like a football field or whatever.
Well, my guess is the majority of these, probably all of them, were 24 to 72 hours.
Yeah, that's too late for a clinical make-believe.
Thanks, John.
You're welcome.
This is a 46-year-old female with evaluation for dislocation and grinding. You can see all the edema surrounding the MCL, concerning for an MCL injury.
So these are the, so what would you call this?
I would call this a grade 2 sprain.
Okay. So the grading of MCL injuries is typically if you see edema adjacent to the MCL, that would be a grade 1. Grade 0 would be normal ACL with no edema next to it. Grade 2 would be edema next to it with a partial tear, but portions of the MCL are completely intact. And then grade 3 would be a complete tear like some of that we've seen there. So I guess I should have gone through the grading system ahead of time. Okay, so this patient had kind of grading, didn't really have a lot of tenderness on the medial side. What do you think of these images in this patient?
I think there's maybe a little bit of lateral translation of the patella with, you can see a joint effusion, and you can't, there's not, the MPFL is just a little thickened and like poorly delineated, I would say, but no obvious complete tear.
Well, so this is a situation where you see that there's severe congenital dysplasia of the anterior compartment. There's actually not a shallow trochlear groove, but a convex trochlear groove back here, a large lateral facet, areas of grade 4 chondromalacia of the patella, marginal osteophytes. So this is someone who has chronic anterior compartment degenerative disease due to patellar instability from trochlear dysplasia. In this case, you can see some thickening of the medial collateral ligament, but it's markedly thin distally here. And this is the area where you saw that edema on the first image. So here, this is the anterior margin of the medial collateral ligament. And here, that would be this area right in through here. So this patient has a perfectly intact, normal medial collateral ligament. The edema we're seeing around it is all due to a peripheral tear of the medial patellofemoral ligament. And I've kind of alluded to the anatomy. I think somewhere I'll go through it in more detail. A major area of insertion of the peripheral portion of the medial collateral ligament is actually to the superficial medial collateral ligament. And it goes to the right canaculum, part of the iliotibial band in this location, but it actually does not attach directly to the femur. So it's a little bit of a misnomer to call it medial patellofemoral ligament, and we'll talk about that later as well. But in my experience, a more common reason why you see edema adjacent to the medial collateral ligament and standard clinical practice like we have is patellofemoral instability with peripheral tears of the medial patellofemoral ligament rather than partial tears of the medial collateral ligament. So whenever you see this, always look to the anterior compartment to make sure you're not dealing with patellofemoral disease before you call it a grade 1 or 2 tear of the medial collateral ligament. Because that clearly completely changes the patient management between those two.
In this case, the management is conservative, but in other cases, younger people with this condition, I have seen clinicians totally miss the boat. I'm sure you have too, which is unfortunate, but that's the way it is.
Okay, thanks, John.
They're very, clinically, they're very similar.
Okay, good. Yeah, because they can have symptoms and tenderness here for both reasons.
Yeah, unless you have an MRI. And in my youth, I didn't have that luxury.
Right. Okay, let's see. Tayson, here's one image. Here's another image. And here's another image. What's going on here?
So we had kind of this eccentric, somewhat low signal lesion in the tibial metaphysis. Maybe a NOF. I don't know.
Okay, so I guess you could say NOF, and actually a lot of NOFs may be due to this particular pathophysiologic mechanism. Here we have the axial images. We can see it here in this particulars. And this is a chronic bony traction injury from the insertion of the medial collateral ligament down here. So this is basically a tug lesion. It's a chronic repetitive traction injury to the bone. And some NOFs, what we call NOFs, may be due to that same mechanism.
Okay.
Probably not all, but that's what this is. So if you see that, just remember you can get these chronic bony reactive changes wherever you have chronic repetitive traction injuries. And you've already seen many cases already in the shoulder. We often get not only this lesion but cystic changes in that area at the rotator cuff insertions. We see that every day.
Yeah.
You can see it at the gastrocnemius origins from the posterior aspect of the lateral femoral metaphyses very, very commonly as well, where they're often called NOFs. Okay. And that's a chronic traction injury.
So along the medial tibia there, metaphysis, we see this lucent lesion right near the cortex. There's no cortical break.
Hard to say there, maybe.
Okay,
Okay,
maybe.
so they thought this might be a neoplasm.
Okay.
So they ordered an MR examination. That's an MR.
Well, it's at that distal attachment of the MCL. I mean, some fluid
And
there.
nice and sharply marginated. You don't really see a periosteal reaction. The cortex looks like it's grossly intact. It looks more cystic than anything else here. And this is another tug lesion, not a neoplasm. So we're able to reassure them with that case. Okay. Robert.
All right, so we have an 18-year-old soccer player with medial knee pain. Looking at the MCL, looks like it's torn proximally.
Okay. So here we have, we don't see the fibers intact here, so this would be a grade 3 tear. It's not really that displaced. So when I started practice, this would be surgical. In the last 2 or 3 decades, this is non-surgical. These heal very nicely without having to do surgery. And the patient was followed up a couple of years later for another reason, and this is what it looked like. What do you see here?
So it looks like that has scarred down and healed.
Okay. So I want to point this to show you this is classically, we see this all the time, thickening of the medial collateral ligament. And this is just an indication that the patient had a prior injury that's healed with scarring. And that's a typical healing pattern. People call this all kinds of things. A common one would be a chronic sprain of the medial collateral ligament. I don't like that terminology because I grew up saying that sprains were acute injuries. I like to just call this evidence of a prior injury or a healed injury or something like that. And you'll see this all the time. It's typically, these are not symptomatic and these are not treatable lesions.
That's a process of healing. What's going on in that 06 film, right, lateral compartment, John? What's going on in there?
Well, let's see. This is just a little partial volume of the very anterior edge of the lateral meniscus. We're just partial voluming it. This is the iliotibial band.
Yeah, I mean the bone inside the
right in
central
here.
area.
These are areas of normal subchondral trabecular thickening in areas where you have a stress pattern within the bone. This is okay. Is that what you mean? John, is this the area you're concerned about?
Yeah, well, I'm concerned about the central area. And there looks like there are two bones there, right there. Yeah.
Here and here, those two things. These are areas of fat.
And totally central. What is that round object?
This?
Yeah.
Yeah, this is fat within the anterior notch. These are soft tissue fat. It's not inside bone.
Yeah, I figured that it had to be fat because of the next film that you had in 09.
Right there. Yeah. Okay.
Sure looks like bone, though.
So here, looks like there's a bunch of fluid. Against the MCL, deep to the MCL.
Okay. So this, we used to be more concerned about this in the early days of MRI imaging. This is fluid that we can see deep to the superficial MCL, and this is often called medial bursitis. I don't think it's inflammatory. I think this is usually due to kind of chronic repetitive injury in this location, and it tends not to be symptomatic, and it tends not to be directly treatable. But some people will call this a medial bursitis. It may be associated with partial tears of the deep medial collateral ligament, which is really the capsule. The capsule is not really structurally significant to the medial side. The structurally significant component is the superficial medial collateral ligament. And this will tend to go away in future imaging, so it may be something to do with trauma. Okay, the next thing that, as far as this medial side, be concerned about is Pellegrini Striata disease. It has been graded a number of different ways. Type 1 is where you have calcification involving the proximal aspect of the superficial medial collateral ligament. Type 2, you only have it kind of centrally. Type 3, the calcification goes proximally into the adductor magnus muscle distally here. And type 4 is much more extensive. I don't really use this typing system. Most of the time, these are going to be type 1, where you'll have ossification within the proximal medial collateral ligament. This, again, is indication of prior injury. It often heals with a little bit of hemorrhage into the collateral ligament, and that can then ossify over time. We'll see a number of areas in lectures throughout this year where we'll see ossicles in specific locations within tendons and ligaments that in the past have been called congenital lesions, normal variants, but there's very strong evidence that the majority of these are acquired, or many of them are acquired in certain locations due to prior trauma to the ligament or the tendon. And I'll show examples of injuries that have been followed up and have ossicles in the area of the partial tears as we go forward. So ossification of the medial collateral ligament typically occurs secondary to partial tears in kids, or even full thickness tears that heal, as we've seen in kids. And that healing can be left with thickening of the ligament, or it can actually be due to thickening of ligament with ossification. It's called.
I ignored that condition in terms of treatment.
Okay.
So looks like there's been an ACL reconstruction.
Okay.
The proximal aspect of the MCL does look thick and heterogeneous, and yeah, I guess that is a small ossification right there.
Okay, so we have this is probably an osteophyte here and a little ossification within the proximal MCL. So this would be Pellegrini Striata type 1. Another appearance can look like this, where you don't have actual fat within the area of calcification. You just see dystrophic calcification of the proximal medial collateral ligament. That's also a Pellegrini Striata type lesion.
Okay. So we're looking at the proximal attachment of the MCL. Maybe there's some fluid there. The MCL looks intact.
Okay.
Yeah.
And a little bit of bone edema over here.
Mm-hmm.
Okay. So this is, what tendon is this?
That's adductor magnus.
I think the adductor magnus would be more medially here. I think that might be the, well, let's see, follow it down. Yeah, see. Oh, you're right. Right. It goes down and actually attaches to the femur here, so that's the adductor magnus, right?
Okay, the attachment there. Okay.
Good. So that's the adductor magnus attachment. Good. And here we can see it on the sagittal images, the adductor magnus coming down and attaching there. Good. And
Anthesophyte there?
gonna have to, maybe a little bit. I'm trying to remember why I have these here. Oh, let's go back here for a second. Oh, okay. And so this is probably some edema right around the adductor magnus insertion. Here's the adductor magnus coming down, little bit thickened with edema adjacent to it. And then here we can follow the adductors magnus down. This is a T2 weighted image. We really need more of a PD fat set, but we can see some soft tissue thickening here. And this was a strain of the adductor magnus tendon with a little bit of soft tissue edema adjacent to it in this particular patient.
Mhm.
And this patient had
Splint.
valgus. We had a valgus injury here where you can see impaction here, traction over there. So this was a valgus stretching injury to the adductor magnus. Good. Good pickup. John?
Treat it with a splint.
Okay. Okay.
So we have a 14-year-old with a side tackle after blocking a field goal. Looks like there may be an avulsion fracture there.
Okay.
Let's see.
And where is that?
It's,
What is this?
it's at that same
Right.
adductor magnus.
Yeah. So that's the adductor magnus attachment there. And this is a little avulsion fracture of the adductor magnus attachment. You can see that there's a lot of edema within the surrounding soft tissues. There was a little calcification in this on the plain films. So you could say this is a Pellegrini Stieta type 3 injury, but this is really more of an acute injury, whereas Pellegrini Stieta is typically a more chronic condition after it is healed. So I personally wouldn't call it an acute injury like this Pellegrini Stieta. Okay. Jake?
Looks like again we got a bunch of edema by that superior medial femoral condyle in a small possibly a avulsed fragment.
Yeah,
Bone there.
calcification, something there. And then here we can see
Yeah.
signaling homogeneity in through here, some areas of low signal, which may well be calcification. And this was calcified on plain films by history from the referring physician. So this would be another kind of Pellegrini Stieta. This would be more of a chronic condition because looks more like dystrophic calcium deposits. John?
No problem with an acute aggravation.
Okay.
I think.
Yep. Jason?
All right, so it looks like there are some post-surgical changes to the medial femoral
Okay.
epicondyle.
Okay, so this was an old medial collateral ligament repair. This location. And then here we can see what the axial images look like with the metal artifact. This is an old study from probably close to 30 years ago now. Okay. Alrighty. Elior, what's happening here?
All right, so we have this hardware on the medial side. The MCL, it maybe looks thickened, maybe it looks intact, but there's just a lot of soft tissue thickening in that area.
So this patient came in with first limited range of motion after surgery, and then got a little bit of the motion back, but has a lot of severe pain on the medial side.
Maybe I'd be worried about. Well, there isn't a lot of edema, so I don't know if that MCL is torn.
Okay. So what this is an MCL graft.
Okay.
And if you notice, the proximal fixation screw is near the anatomic origin of the MCL, but the distal fixation screw isn't anywhere near the insertion point of the MCL. The insertion point should be way down here, and there's a reason why anatomically the insertion point is way down in the metaphysis of the tibia. Why is that? Okay.
I don't
The
know if it's
reason
something-
is that if you attach it up here in a non-anatomic position, that's going to constrain the knee and you'll get loss of motion of the knee.
Mm.
So this patient had loss of motion and postoperative pain because this is a non-anatomic positioning of the graft. And he eventually tore this graft and he got motion back.
Yeah, this is a poor construct.
Yeah.
Number one, screws in this area are not very good. In fact, they're harmful, in my opinion. As you said, John, the placement of that distal screw in the tibia proximally is pretty awful.
Yeah. So this was graft failure from poor placement of the graft. Robert?
All right. So we have two correlates of the knee. Looks like there's fixation hardware at the MCL. Looks like there's another one distally, closer to where it should be at least. There's the graft looks like it's intact. It's a lot of soft tissue kind of medially.
Yeah, but it's not very taut.
Right.
It's really bowed out here. And this was a stretched graft, a medial graft. And again, fortunately, we don't see these very often anymore. But obviously, this is not going to function very well to stabilize the medial side of the knee because it's too loose at this point. And you can see chronic traction injury here at the distal insertion, showing that there was a lot of abnormal traction on the distal insertion, which is probably still a little bit too proximal here to actually have normal motion.
There's a lot of problems with this knee.
Yeah. Okay. So let's move on to the anterior cruciate ligament now. We've kind of beaten the medial collateral ligament to death. So anterior cruciate ligament, let's talk a little bit about anatomy, impingement processes, different tear types, cysts, and then end up with how to treat these when they're torn. So here's the typical anterior cruciate ligament. You're all familiar with it. It typically is divided into two bands, anterior medial and posterior lateral. Here's the anterior medial band. The posterior lateral band would be these fibers back here. Sometimes you can see two discrete bands by MR. Often you can't. Typically, you'll see a nice black line anteriorly, but the mid and posterior fibers are often higher in signal intensity, and that's because structurally, the anterior medial band has much thicker type 1 collagen fibers in it than the posterior lateral band. But here we can see nice structures. In a normal ACL, you really should see nice internal anatomy and structuring, especially distally. You'll typically see a striated appearance distally, less commonly seen more proximally in these particular patients. And just because you see a little bit of signaling, that doesn't mean it's abnormal or tendinotic. When you start, if you can see the nice sharp planes of the different fibers, then you're pretty much dealing with a normal ACL. Once you start getting tendinosis or mucodegenerative change, you lose this nice fine anatomy of the internal structure. So if you see it, then you're probably dealing with normal. So here we can see a nice anterior medial band, a little posterior lateral band there. If we do a cross-sectional image through there, you can see it looks like this: anterior medial band, posterior lateral band, here and here. And another example, anterior medial band, posterior lateral band. I'm showing this anatomy because when we get to doing surgery, there are typically two options. Well, there are many options, but two common options are to either put in one graft or put in separate grafts for the two bands. And we'll talk about the pros and cons of both of those. Here we can see a gross specimen of the anterior medial band and the posterior lateral band. And this just shows the origin of the anterior medial band and the posterior lateral band are slightly different locations on the femur. The anterior medial band is higher, the posterior lateral band is lower. Here we can see the anterior medial band. It tends to be uh, well, here we can see the anterior medial band. It tends to be lax in extension and becomes taut in flexion, and the opposite for the PCL, for the posterolateral band.
Flexion and extension causes rotation of the ACL.
Right. So they kind of wrap around each other, and it helps to then shorten them and improve the stability of the joint because of that.
But if you try to replace them individually, it's just too damn hard for yours truly. So I leave it to the very adept surgeons.
Yeah, we'll talk about that surgery in future lectures.
Okay.
Right.
I'm just kind of
Good.
before I forget, John.
And then here we can see when you start getting mucodegenerative disease, it tends to occur predominantly in the posterior aspects, and you can see diffuse increased signal. You can see a little bit of fibers, but we don't see that sharp differentiation between the fibers. Still, there's an intact anterior portion of the anterior medial band, and this is what mucodegenerative change looks like in the ACL. When you see this is generally due just to overuse and stretching of the ACL, and then tries to heal itself with granulation tissue, and this is just the appearance of granulation tissue. Things you need to look for, however, here is a very bright ACL due to mucodegenerative change, and what you can see here on the lateral aspect of the notch of the knee, you have an osteophyte, which is edematous. So this is called lateral wall impingement on the ACL. Occasionally, this can become significant enough where people will go in and remove these osteophytes. The problem, if you go in and remove them, they have a tendency to grow back again. But this can actually weaken the ACL and predispose to ACL rupture. So this is impingement of the ACL. Here's another example of a lateral wall osteophyte here with edema in it due to the chronic repetitive trauma from the ACL. And then you can see this severe degenerative disease of the ACL due to impingement from the lateral wall osteophyte. So this is called lateral impingement. You can also have roof. Go ahead, John. You can also have osteophytes on the roof of the notch. This is a big osteophyte on the roof. This can also press down on the ACL, producing impingement. And here we can see abnormal signal intensity within the anterior cruciate ligament here, and this patient with a roof osteophyte.
Is that an osteophyte or is it a fracture, John?
I think this is an osteophyte.
Not a healed fracture.
No, I don't think it's a fracture.
It kind of looks like a whole healed.
We can see osteophytes over here as well.
Yeah, it's all over, but that one looks like it's an old fracture.
Well,
ACL probably.
Yeah, but
Maybe I'm wrong, but
the origin of the ACL is way up here, not near where this fracture
sure
would be, and there's nothing that really attaches here. So I think this is a pretty common location for degenerative osteophytes.
Look at the patella where that's sitting. That's a patella baja.
Yep.
That's about as baja as you can get almost, unless a surgeon did it.
Well,
But
yeah.
that's an interesting name.
Yeah, well, I call that Yergudis disease rather than patella baja. Since
Well,
Dr. Yergudis is the person who coined the term patella baja.
yeah.
Okay, let's go on to partial tears. So you can get acute partial tears that have diffuse edema within the ACL, like we see here. This is very difficult to differentiate between mucodegenerative disease unless you have a prior MR scan before the trauma. but acute injuries, and here we can see some acute edema within the bone here. So this is an acute strain of the anterior cruciate ligament. Oops, I'm sorry. I guess this is microdegenerative disease. As I said, it's hard to differentiate between the two. Here's a situation where on 12/28/07, we can see a nice dark ACL in this particular patient. This is now a few months later, and notice in the interval here, the patient had trauma, and this is now looks like microdegenerative disease, but this is actually an acute injury, a partial tear of the anterior cruciate ligament. But it looks just like tendinosis. With injuries, you can also get partial tears in ligamentous cysts. You can have them both inside the ligament or adjacent to the ligament. They're typically called paracruciate cysts, and they're probably actually secondary to partial tears of the cruciate ligaments, which we can see here. These typically, the ligament that we see is intact, and these typically are not treated. ACL cyst. Here's another larger cyst back here, again a paracruciate cyst. Most of these probably come from the ACL, but here we can see here. Occasionally, there's some debate about whether these could cause symptoms, but I'm not aware of any papers that have clearly shown that these are symptomatic or need to be treated by drainage.
I've never treated one.
Yeah. See, who's next?
I can go.
Okay, go ahead.
Yeah, 58-year-old male, twisting injury. Yeah, looking at the ACL, we see some edema between the anterior medial and posterior lateral band. Yeah, maybe is it the posterior lateral band that looks like it's more edematous?
Yeah, so this was a partial tear to the posterior lateral band. Some people believe that partial tears of the ACL, some of them should be treated surgically if they have any form of clinical instability. And we tried to do a study about 5 years ago, kind of looking at this. But what I found out in looking at a not large series of patients that we had, all have had surgery, is that I couldn't find any clear-cut MRI findings that would differentiate people who the surgeon thought benefited from surgery than the ones that they thought wouldn't benefit from surgery. I would certainly call this clinically. There are people who will do an isolated posterior lateral band graft, but the vast majority of partial ACL tears are treated conservatively. But this was a partial tear.
All right. So we have a coronal of the knee. Looks like the ACL is probably torn proximally there.
Yeah, we're not really far posterior enough to be able to see the proximal origin. Here's just the anterior medial band, the posterior lateral band. But if we start going posteriorly, what do you see here?
Yeah, I see some fluid signal there, so I think it's torn.
There we can see something here and something there. So, and then here if we go back here, the anterior medial band attached up here. This is the posterior lateral band and what's happening to it.
Looks like it's not attached where it's supposed to be.
It's staying down low, right? It's staying displaced. Here we can see it displaced on the axial images. And so here's kind of the anterior medial band. And then here's actually a torn posterior lateral band where the posterior lateral band is inferiorly displaced. So this is another partial tear, which is an isolated tear to the posterior lateral band. Okay, Jake?
It looks like on this, the anterior medial band, I don't really see a continuity of that. The posterior medial or posterior lateral looks like maybe there's some fibers there, so I'd probably say partial tear of the anterior medial.
Here's the posterior lateral band, and not really seeing the proximal part, but They're in a slightly different plane, so you could partial volume them. So you'd want to look carefully. If we go to the T2 weighted image, we have a little bit better signal and the contrast on the T2 weighted image, where we have a nice black intact anterior medial band. Posterolateral band actually looks like it's kind of inferiorly displaced posteriorly with some fluid adjacent to it. On the axial images, we're seeing some abnormal signal there, and this was another isolated tear of the posterolateral band. In this particular case, what can happen is the ACL can inferiorly displaced and it can adhere to the posterior cruciate ligament, which is what happened in this particular case. So sometimes you can have a complete tear of the ACL and it looks like it kind of goes up to where it's supposed to go, but what happens, it falls down here, adheres to the PCL and doesn't completely displace to the tibia. Yes, John?
I've seen a few, and I did when I was doing surgery, and it's very interesting to see that laying down on the tibia like that and attached to the PCL. And sometimes you get fooled in terms of stability because there's some fibers that may be intact. So
Thank you, John. Great.
it's an interesting situation.
Yeah. Well, why don't we stop here and we'll go to grade 3 tears tomorrow. Okay? Any
Sounds good.
questions? Okay. Thanks.
Have a good time, everybody.
All right.
And